Good afternoon and welcome to Webinar Wednesday. We're excited to have over 330 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday t-shirt for answering this trivia question. Today's sponsor, Rigel Medical, has its US office based in Florida. Name one of Florida's NFL teams. Answer now using the questions feature on your dashboard. While you're answering, I want to invite everyone to save the date for 2020 for 2 of our expos. First, for our ICE Imaging Expo, which will take place at the Hilton Scottsdale Resort in Scottsdale, Arizona, from February the 9th to the 11th, which will bring imaging service professionals from across the nation for 3 days of learning, networking, and the latest advances in imaging. More details can be found at attendice.com. And secondly, for our Spring MD Expo, which will be taking place at the Hotel Irvine, California, April 20th to the 22nd, which will bring together HTM professionals from across the nation. Again, more details can be found at mdexposhow.com. Okay, and let's see who the winner of our Webinar Wednesday t-shirt is. It is Wayne Paulson. Congratulations, Wayne. The correct answer, of course, is Miami Dolphins. Webinar Wednesday would like to thank our sponsor, Rigel Medical. Rigel Medical is a leading manufacturer of biomedical test equipment, including electrical safety analyzers, vital signs simulators, infusion pump analyzers, electrical surgical analyzers, and Medi-based asset management software. For more information, visit rigelmedical.com/USA. Our presenter today is Brittany Smykel, National Business Development Manager at Rigel Medical. Brittany, you may begin whenever you're ready.
Hello, everyone. I hope you guys are all having a fabulous Wednesday. This is Brittany Schmidtke. I am the National Business Development Manager here at Rigel, Florida, based out of beautiful Tampa, Florida. Today, I am going to walk you guys through vital signs simulations, and all of these kind of involving blood pressure, both invasive and non-invasive, blood oxygen saturation, electrocardiographs or ECGs, temperature, and respiration. So our agenda for today, for the next 45 minutes or so, I'm going to give you a little bit of the introduction and history of vital signs, a brief look at the respiratory system and its importance, the common vital signs that we really focus on when monitoring a patient. Then we'll dig a little deeper into blood pressure, blood oxygen saturation or the SpO2, the electrocardiogram or ECG, temperature, and respiration. We do have a brief video at the end showing you a little bit of the setup and the PM process on a patient monitor. And then we will leave some time at the end for some closing remarks. So if anyone has any questions along the way, just jot those down. And we will have some time for Q&A at the very end as well. So getting started. Vital signs are really 4 to 6 of the most important signs that are going to indicate the state of a person's health. You'll also sometimes hear them referred to as life-sustaining functions. These are the ones, the signs that you're going to hear the most about in a clinical environment, especially when it comes to monitoring the patient. These measurements are taken to help assess the general physical health of a person, give clues to possible diseases, and show progress toward recovery. So basically answering the questions, how is the patient doing? Is the medication working? Do we need to change or alter the treatment plan at all? So when we're looking at these vital signs, there are some factors that can affect what's deemed a normal range for a person. Some of these could be the person's age, their weight, gender, and basically their overall health. So some of the history of vital signs. Monitoring a specific part of a patient's makeup can actually be traced all the way back to 1874, where they actually tried measuring blood saturation in a human hand at that point. By 1918, quantitative oximetry was developed. By 1935, we saw the first oxygen saturation meter in action. An actual vital signs monitor began with Seymour London. So he was an American physician and inventor from Florida, and he is the one who designed the first automatic blood pressure monitor. So he started looking into this and developing it after he found that taking the manual readings over and over were really just a pain. There had to be a quicker way. So that is how he designed the first monitor. So he used a blood pressure cuff, a column of mercury, a microphone, and a fish tank pump to develop this. He then took his device to a medical convention in 1965, where he had 400 of his colleagues test it. And what they have all found after testing it is that there really was no difference between the new device that he had developed and the hand-taken readings. Okay, so next we're going to take a quick look at the respiratory system. So all vital signs are directly related to the operation and function of the respiratory system. Temperature and blood pressure are the most common ones that we're going to measure and monitor in a clinical environment. There are multiple roles that are performed by the respiratory system, however. So those are pulmonary ventilation, external respiration, internal respiration, transportation of gases, and homeostatic control of respiration. So I'll just give you a brief description of each of these processes. So pulmonary ventilation. This is the process of air flowing into and out of the lungs when the lungs muscles contract. So our lungs also have a negative pressure system built in, and this is due to a really thin layer of tissue called the pleural membrane that covers the lungs. So when the lungs are completely sealed inside this membrane, they are going to be at a slightly lower pressure than when they're at rest. So because of this, the air will passively fill the lungs until there's no longer a pressure difference. And if necessary at that point, you can always inhale additional air. But when you exhale, the muscles will relax, increasing the pressure on the outside of the lungs and forcing air to escape until the pressures equalize again. So since our lungs are naturally very elastic, they can easily revert back to a resting state, and then the entire process will just repeat itself. External respiration is going to be the process of a gas exchange, and that'll be between the air sacs in the lungs and the blood and the capillaries. So basically, oxygen from the air goes into the blood, and carbon dioxide will go from the blood to the air. Next would be internal respiration. So this is similar to the external respiration, except that it's going to involve a gas exchange between blood and the capillaries and then your body tissue. So oxygen leaves the blood and enters the tissue. Carbon dioxide does the opposite. Next is the transportation of gases. So this part of the respiratory system allows for oxygen and carbon dioxide to travel to the body to wherever it's needed at that time. So most gases are carried by blood, and they attach to the molecules such as hemoglobin. Actually, almost 99% of the entire oxygen found in your body is transported by hemoglobin. However, carbon dioxide is transported from all over your body back to your lungs by plasma. And that's where it's going to be exhaled. The gas exchange is going to occur. And then lastly, we have homeostatic control of respiration. So this is the last role of the respiratory system, and it's really just the body's way of maintaining a steady breathing rate. So the rate should remain constant until the body needs more oxygen, like when you're exercising or doing other physical activity. So when this happens, the receptors in your body will actually pick up on the pressure changes, and they will send triggers to the brain. So at that point, the brain will then tell the respiratory system to make the necessary adjustments to the breathing rate to meet the need for more oxygen. So moving on to common vital signs. So as we talked about before, primal vital signs are invasive and non-invasive blood pressure, SpO2, ECG, temperature, and respiration. So blood pressure. This is the most common vital sign that's monitored. Basically, you're going to have both systolic and diastolic pressures. The systolic is when the ventricle contracts, and this is when your blood pressure is going to be at its highest. And diastolic is when your blood pressure is at the lowest, and that's so that it's easier to circulate throughout your body. So both your blood flow and pressure are going to change throughout the cardiac cycle, and those are going to be recorded as millimeters of mercury. Oops, sorry. There we go. Okay, so some factors that can affect your blood pressure will be things like age, weight, lifestyle, health issues. That's why when your blood pressure is high, the first thing your doctor is going to say is that you need to lose weight and you need to exercise. So some basic terminology surrounding blood pressure: hypotension. This is when you have an abnormally low blood pressure. Hypertension would be when you have an abnormally high blood pressure. So the pressure can be measured both invasively and non-invasively. Non-invasively would be the typical cuff that your clinician uses or that you see in the office when you go to the doctor, or it can be measured invasively, and that is when it's measured actually within the blood vessels. Non-invasive is definitely the most common, but invasive is actually more accurate of the two. So there's several ways to test your non-invasive blood pressure. The first one, you can see the picture at the top left there, is the palpitation or the feeling method. So this is what's usually used in emergency situations where there's a significant amount of blood loss, or even in trauma cases when there's just not a lot of time to get the patient's blood pressure. And what they're going to do is they're going to do it by feeling the pressure, usually through the inside of the wrist. This is something that you see on all the medical dramas and movies and all of that out there. Second would be the oscillation method, and you can see the picture to the left there as well. So this is when you determine the pressure by listening. So when the blood flows and it is blocked and then released by the external cuff, you're going to actually listen for the pressure. And with this method, there comes a sort of beating sound that is known in the medical field as the Korsakoff sound. So this is usually done with a stethoscope in an office setting, just like you see in the picture there. And then lastly, we have the oscillometric method, and this measures the systolic and diastolic pressures that come from the difference in pressures within the cuff when it inflates and then when it deflates. And this is basically due to automation and electric pressure sensors that are actually used to determine the final pressure. Okay, so next we're going to look at testing your NIBP monitor. This is going to start with a pressure leak test. The purpose of this is just to verify the integrity of the system, and that includes the integrity of the tubing and of the cuff as well. The leak test will basically measure the pressure drop over time, and these numbers have to fall within certain specs according to the manufacturer of the monitor or the cuff that you're testing. You're then going to do a system overpressure valve test. So this is just to verify that the system is able to vent when the pressures reach a value that exceeds what is safe for the patient. Next, you're going to do the dynamic pressure test. This is the one that's going to prove the accuracy of the monitor, but under dynamic pressures. And this is always going to be done in real conditions. So for example, it would be like testing a patient with a very low blood pressure of say 80/40 with a heart rate of, let's say, 80, and then the polar opposite, a patient with a very high blood pressure of, let's say, 180/140, but also with a heart rate of 80. And then lastly, you are going to test the alarms. So as you guys know, monitors have both audible and visual alarms, and these can vary from manufacturer to manufacturer. So you really just have to refer to the monitor's manual and follow that as to the different alarm conditions and what actually needs to be tested. Okay, now invasive blood pressure. This is going to involve directly measuring the arterial pressure. So how they do this, a cannula needle is going to be inserted into either the radial, brachial, femoral, or the axillary artery. The cannula has to be connected to a sterile and fluid-filled system, which is then going to be connected to your patient monitor. So the advantage of this technique is it's much more accurate because it's getting the patient's blood pressure constantly, beat by beat, and it's also an advantage because a waveform can be displayed for you. So this is what you're mainly going to see used in the ICU and the OR, most likely. So how do we test invasive blood pressure? First, the static pressure tests are good for verifying the performance of the pressure transducer, and it's actually good at measuring the accuracy of the actual monitor, and that's over different pressure ranges. And then the dynamic pressure test is going to verify the accuracy of the pressure transducer as well as the monitor. And usually these values should fall between like within plus or minus 3 millimeters of mercury. And like I said, that will vary manufacturer to manufacturer, but that's around the range that you're most likely going to see. Okay, so we're going to move on to the next vital sign, pulse oximetry, or SpO2. So this is when the oxygen is absorbed into the blood and it passes through your lungs. So the oxygen is actually going to stick to the hemoglobin in your red blood cells and kind of use it as a means of transportation. And here the normal range is considered to be a reading of around 95 to 98. Okay, so this slide can basically be summed up by the fact that pulse oximetry uses light to work out oxygen saturation. The light is emitted from sources that go across the pulse oximeter probe, and then they reach the light detector. So if a finger is placed in between the light source and the light detector, the light has to pass through the finger to reach the detector. So part of that light will obviously be absorbed by the finger, and the part not absorbed by the finger is what's going to reach the detector on the other end. So the amount of light that absorbs by the finger depends on a couple of properties that are taking place. Property number one is known as Beer's law, and this says that the amount of light absorbed is proportional to the concentration of the light absorbing substance. So for example, hemoglobin absorbs light very well. So the amount that's in the blood vessel is going to affect the amount of light that is absorbed. So let's say you have two blood vessels, each the same in diameter, but one has a higher level of hemoglobin concentration. That is going to be the one that will absorb the most light. And by measuring how much light actually reaches the detector, the pulse oximeter can then calculate the rate. Property number two is known as Lambert's law. And that states that the amount of light absorbed is proportional to the length of the light path. So the light that is emitted from the source has to travel through the artery. It's going to travel a shorter path in a more narrow artery and obviously longer in a wider artery. So even if the hemoglobin concentration is the same in both of the arteries, the light is going to meet more hemoglobin in the wider one since it has to travel a longer path. So looking at testing your SpO2 monitor. The bottom line here is that it's going to differ as to how you test, as we've said a couple times before, just from manufacturer to manufacturer. So basically just follow the manual for that particular piece of equipment. However, some of the common failures you'll see here will either be a bad sensor or the probe is not properly placed. Okay, looking at electrocardiographs or electrocardiograms, ECGs. Okay, the definition is an instrument for recording the changes of electrical potential occurring during the heartbeat. It is used to detect the electrical signals associated with cardiac activity and produce an ECG, a graphic record of the voltage versus times. So these are pretty commonly used to diagnose and also to aid in the treatment plan of several types of heart diseases, things like arrhythmias, etc. They can also help to see how a patient is responding to their drug therapy. And some of the more modern EKGs can actually run automatic measurement sequences, and they can interpret as well. And those are usually optional features there. So here we have Einthoven's triangle. The definition is Einthoven's triangle is an imaginary formation of 3 limb leads in a triangle used in electrocardiography, formed by the 2 shoulders and the pubis. The shape forms an inverted equilateral triangle with the heart at the center that produces 0 potential when the voltages are summed. So here you can see the 3 leads. Lead 1 is left arm to right arm, lead 2 left leg to right arm, and lead 3 left leg to left arm. And so all of these leads will produce 0 potential when they are summed up. Okay, so here we're looking at the precordial and augmented limb leads. The precordial leads. Each consist of a positive electrode strategically placed on the chest of the patient. The positions of the positive electrode for the 6 precordial leads are very important for a valid tracing to be made on the EKG machine. So these are often used to get a more detailed ECG or look at the heart, just because they're placed in such close proximity to it. And these are going to be labeled V1 through V6. Now looking at the augmented limb leads, these are derived from the same 3 electrodes as leads 1, 2, and 3, but they use Goldberger central terminal as their negative pole. Goldberger central terminal is a combination of inputs from 2 limb electrodes with a different combination for each augmented lead. And these are going to be labeled AVL, AVF, and AVR. So those are all of your EKG leads. Currently, there are 2 color coding standards for any 12-lead ECG. First is the IEC, the International Electrotechnical Commission, I believe, and the AHA, the American Heart Association. So here you can see both tables showing the color matched with the appropriate electrode. And here is a look at the placement of each of the color-coded electrodes on the body. So you're looking at the precordial ones in the picture on the left, all placed closely to the heart. And then your regular leads for the arms and legs, you'll see on the picture on the right. Okay, now we're going to look at the simulation and performance test that needs to be completed for preventative maintenance. You're going to be doing a linearity of heart rate measurement test, an alarm test, both high and low, as well as for disconnected cables, an arrhythmia recognition test, and then lastly, a sensibility test. So first, the linearity of heart measurements. So this is used to verify the capability of the monitor and that it is able to display the heart rate accurately. You're probably going to test several different values, usually ranging from about 30 to 300 beats per minute. Next, you're going to test the alarms. So the IEC 60601-1-8 that deals with monitors provides the requirements for alarms on all medical devices. Keep in mind again that the alarms will vary in frequency, pitch, volume, and melody from manufacturer to manufacturer. Okay, next will be the arrhythmia recognition test. This is done because ECG monitors that are able to actually interpret the ECG recording, they are required to provide an alarm when they detect a seizure in the blood, circulation, or a lack of a pulse. And lastly, the sensitivity test. This is to ensure that the input circuits of the ECG recorder, that they're sensitive enough to measure the ECG millivolt signals, that they can measure it that low. And we are going to move on to temperature. So this is the other vital sign that is measured and monitored the most. Now, core body temperature does vary by gender, health status. It can even vary as to what time of day it is. But the average core body temperature is around 98.6 degrees. And then the most common sensors used, especially on bedside monitors, are the electrical temperature sensors. And the YSI 400 and YSI 700 are basically the standard for these. Now, when you're testing temperature, you're going to do a linearity of temperature measurement test and an alarm test, both high and low. The linearity test is going to be testing the monitor really over the most typical range of temperature, so normal body temperature, fever, hypothermia, and your room temperature. And usually a simulator can simulate across the range of between 75 and 105 degrees. So moving on to the alarm test. Once again, the temperature monitors have alarms that need to indicate when an acceptable temperature has changed. So it's either gone too high or too low. And with these simulators, normal is considered 98.6 degrees Fahrenheit. The lows are around 91. The high is around 106. And room temperature is considered 77 degrees Fahrenheit. On to respiration. So the respiration rate is the number of breaths that you take each minute. It's usually measured when you're at rest and just involves counting the number of breaths that you breathe for an entire minute. This is obviously gonna fluctuate with exercise, with fever, illness, etc. Normal respiration rates for an adult at rest is going to be 12 to 20 beats per minute. But when you're exercising, the rate can actually increase to 40 to 50 breaths per minute. So an alarm test needs to be done once again to ensure that the device is going to alarm when the rate falls outside of the set parameters. And once again, you'll need to follow the manual of the particular manufacturer on the device that you're testing. Okay, so now we are going to look at a quick video showing the typical setup of a patient simulator when you're doing a PM on a patient monitor. Here we are looking at the connections on the back of the unit. There we go. Can you get it from the beginning? Just playing. Just 1 second, please. Okay, so from the beginning, this is going to be what you're going to need to do the testing. To the left of the device, we have the EKG paddle box adapter, the SpO2 pulsar for testing the oximetry. Above the device was the pressure cylinder, and then you're going to have your tubing connections and your temperature cables. Moving on to a look at the connections on the back of the unit. Starting from the top left, you're going to see the temperature simulation output. Next to that is the EKG simulation output, the IBP simulation output. At the bottom of the unit, we have the mains power connection, the SpO2 simulation output connection, and the NIBP simulation output. Okay, so here you can see the connections that are made frontal view of the unit. And once these connections are made and all set up, you can turn on your monitor to begin testing. So you can see as we turn on the simulator, the monitor is going to jump to life as well, starting to mimic the simulator settings that you see on the screen, and we'll get a closer look of that screen just a second. There we go. The monitor slowly trying to catch up with the simulator there. So we do have all 6 simulations that are happening at the same time with this device. And we're going to zoom in here so you can get a closer look at all 6 of those measurements that are happening simultaneously. So you can see the heart rate and the temperature on the left. You'll see the respiratory rate, blood pressure readings. So the monitor is slowly starting to catch up there. This is actually a monitor that we really just use for demo videos and such, so the numbers might be slightly off there. So now we're really, and this is all done on the fly we're doing right here, just gonna start kind of playing with the numbers so you can see it a little more in action. So changing up the respiration, changing up some of the parameters for the blood pressure, for the temperature, some different arrhythmias. And then you can see the monitor is mimicking what the simulator is doing. So like I said, you can change any of those numbers, any of those parameters on the fly. And then you can also go into the settings. I believe that's what we are about to do. And you can customize all of the parameters as well. So we can do it both on the fly, and then we can actually do it in the settings as to what you want the parameters to be. Okay, so we're changing the SpO2 now to 100%, and then you can see the monitors climbing, jumped from 82 to 96. Now we're at 99, which is probably the best we're going to get from this monitor. Okay, we've changed the BPM. And like I said, we're really just playing around with numbers here so that you can see, you know, anything that you might run into during a PM. Okay, this looks like the change in the blood pressure. So we should notice the numbers changing there. Okay, that monitor's really trying to catch up at this point, but it'll stabilize here in a second with the parameters that are on the device. Okay, so now it's doing the NIBP there at the bottom. And so that's the pressure that's constantly changing. Okay, so that is pretty much a condensed version of the PM that you guys are going to have to do. Okay, so just a quick note on file storage. So I know every facility is different as to how much or how little information you guys need to capture in order to stay in compliance. However, a good rule of thumb would be the date of the inspection, your name, the results of the visual inspection you did, the results of any electrical safety or performance testing that you did, and when the next PM is going to be due. And that's usually enough information to be safe, but I would definitely double check with your facility. So that is the end of my presentation, Linda. Hope you guys learned something.
Thank you so much, Brittany. Yes, we have got a few questions. Can you simulate different signals simultaneously?
Yes, you absolutely can. And you could kind of see that in the video. All 6 of the simulations will show up on the screen, and they will be working at the same time.
Okay, that's great. And so how many different arrhythmias can it simulate?
I believe the device that was in the video, it will simulate 27 different arrhythmias.
Okay, and are the simulations customizable?
Yes, and that's what we were also showing throughout the video as well. Like we said, you can do it while you're just in manual mode, or you can actually go into your setup and you can change them there and customize them as you see fit.
Okay, a couple more questions here. Does SpO2 do low perfusion?
I don't believe this one does, but I can look into that for you, and I will get you an answer for sure.
Okay, another question here is, during a PM, we normally would do a pressure calibration for NIBP and a CO2 gas calibration for ETCO2. What do you have to accomplish these steps?
Hello guys, my name is Joel. We are going to look at these CO2 specifications for you.
He was a BMET in his past life, and he's not too sure about that one. So we're going to look into that one for you as well. I apologize.
Okay, that's no problem. We don't appear to have any more questions at the moment, so I think that's probably a good point to wrap up today's webinar. So thank you again, Brittany, for a great and informative webinar, and thank you again to today's sponsor, Rigel Medical. Just a reminder that the post-webinar survey and certificate process is now automated, so the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately, and one lucky attendee will win an Amazon gift card for completing the survey. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information about all our upcoming webinars, please visit our website, webinarwednesday.live. So thank you once again for joining us. Thank you again, Brittany. Enjoy the rest of your day, and we hope to see you next time.